Hi everyone, my name is Kelsey Brown and I am going to be presenting my evidence-based implementation proposal of surgical smoke evacuators and implementing a policy that will demonstrate best practice in the operating room. Some of the goals and objectives for this presentation is to be able to identify what surgical smoke is and the hazardous effects that it has on patients and staff. You should be able to identify the problem, the purpose, and the intervention that is necessary for the department, and to be able to understand the benefits of surgical smoke evacuators. Medical research has evolved, and everybody in today's world is aware of how harmful smoke is. Smoking has become banned in most places. Surgical smoke, also known as surgical plume, is a global issue in the surgical setting. Surgical smoke is created by electrocautery and laser machines that are used in almost every surgical case in various specialties. For example, laser machines, lasers, are used in a lot of urology cases and most pacemaker laser lead extractions. And cautery machines are used in almost every specialty and almost every surgical case. For example, every surgical case that I am a part of uses cautery machines. Cautery machines are used to cut tissue and control bleeding by coagulating blood vessels. The CDC has confirmed that smoke contains toxic gases and vapors. Surgical smoke causes negative health effects for patients and the surgical staff. According to the Association of Perioperative Registered Nurses, studies have shown that using a carbon dioxide laser is equivalent to smoking 3 unfiltered cigarettes in 15 minutes, and the use of an electrocautery machine is equivalent to smoking 6 unfiltered cigarettes in 15 minutes. Those numbers are scary to think of. Adverse health outcomes related to surgical smoke exposure has been reported, such as HPV, cancer, and bacterial infections. AORN is one of the world's largest professional associations for perioperative nurses. AORN provides evidence-based guidelines. AORN recommends the use of smoke evacuators in all surgical cases that anticipate surgical smoke. In my perioperative department, in my facility, we try and follow all AORN guidelines for best practice. However, this guideline is being skipped. For my evidence-based implementation proposal, I created a PO question, which is revising and implementing a new policy regarding the use of smoke evacuators in the perioperative area demonstrate best practice. Currently, my department has no policy in place for surgical smoke, and surgical smoke evacuators should be utilized in all surgical cases that anticipate surgical smoke. There are many products in today's healthcare that eliminate surgical smoke in the air. One example is ConMed Clearview. It eliminates 99.999% of smoke contaminants in the air. By eliminating the chemicals in the air, we are making the operating room a clearer and healthier environment for the staff and patients. Florence Nightingale's theory focuses on the environment for patients' recovery. Providing the patient with a clean air surgical environment will help the patient's recovery. It's important to provide the best working conditions for the staff that doesn't affect their health as well. In my evidence-based implementation process, I did a literature review. This chart shows the research articles that I discovered. They are all within the last 5 years, and 4 out of 5 of them are quantitative studies. I think that the research shows that surgical smoke is harmful to both patients and staff, and these findings will be key in showing the staff and getting them on board to decreasing any barriers that I will have with staff not wanting to use the smoke evacuators. And this will demonstrate as well that smoke evacuators are best practice. The patient experience also improves when utilizing smoke evacuators. One study, the impact of smoke evacuator on patient experience during Mohs surgery, shows that the patient experience is much higher by utilizing smoke evacuators than not utilizing them. The cases that showed them not using smoke evacuators, the patients all reported a bad odor during their procedure. But overall, I think that these are 5 great research articles that will help in my process in implementing my evidence-based proposal. For my evidence-based implementation intervention plan, I plan to do a 6-month goal, which I think is very obtainable for this whole implementation process. I'm going to first do a shared governance policy change, which I hear takes the longest time to do. So doing that first is very important. My policy will state something as smoke evacuators utilized in all cases that anticipate surgical smoke. So, and present with what cases on that. So staff is fully aware of what cases they should be using them. If they have questions, they can go back to the policy. Doing a pre-implementation survey is important to see what the staff's views are, to see what they think about surgical smoke and the hazardous effects that it has on patients and staff. Being able to gather all that information from the survey and present it back to them is very important to provide them proper education in this implementation process. Providing them with appropriate education is very important, and then being able to do a in-service on the smoke evacuator is also very important. Providing every operating room with a smoke evacuator is crucial, so that eliminates any barriers or obstacles that the nurses have trying to scramble around, trying to find a smoke evacuator for that case that anticipates surgical smoke. I'm going to then implement the policy once the shared governance has gone through, and then I'm going to do an audit, which will consist of check, learn, evaluate, assess, and report. I'm going to then gather all that information and do a post-survey of the staff, and to see what their views are and what kind of information they're receiving from the surgeons, with any feedback that I can present new information for an educational session. And this will be essential to determining if they are using the smoke evacuators properly, if they're using them in the correct cases. I think this will help in the implementation process. Reporting all these findings from the audit and surveys to all key stakeholders will be key in keeping this implementation effective. Becoming aware of the potential risks and taking precautions will demonstrate best practice by protecting patients, your team, and yourself. With this presentation, you should have become more aware of what surgical smoke is and how to eliminate it in the operating room. I think this evidence-based implementation plan will show you all the steps that will be used to initiate this evidence-based practice in my department. I hope everyone understands the surgical smoke effects on patients and staff, and how this evidence-based proposal is appropriate for my department.